Tammy Coker. I originally lived here and grew up in Sylacauga. I graduated from Sylacauga High School, so I'm so happy to be back here and working with Coosa Valley. Dr. Jennie Wheeler and I, we have started in a new program in the hospital. So I've already had a couple of y'all have asked that where is the clinic? Where is the office going to be located? We do not have a clinic or an office. If you have a physician and you're admitted to Coosa Valley Medical Center and your doctor is not one of the doctors who round, in the times now, a lot of the doctors have retired their hospital privileges. They see you see them in their office, but when you come in the hospital, oh, Dr. Lee is not here because he doesn't round in the hospital. So when you get admitted, you would come to our service. It's what we call an unattached hospitalist service. So we would round on you Monday through Friday. You would have that same person seeing you, and it's really good for continuity of care. If you've ever been at UAB or you've been at Grandview or even here before this program, you may have had a different doctor seeing you every third day or every other day. Sometimes having that better set of eyes, we're able to see how you were breathing yesterday, how you're getting up out of the bed. Are you having as much swelling in your legs? Are the medicines working? So we've got this program. We've just started in August, I guess, let's say the first week of August, and we're trying that out at Coosa Valley. I don't want to see any of y'all in there. Dr. Wheeler wants to see your face here. We don't want to have to round on y'all, but if you do, this is a new program. So we'll try it out and see how that works. If you have any questions about that after, we'll be sure to answer any concerns or things you might need to know about it. But what we're here for today is to talk about health maintenance and disease prevention. I can't tell you how many times we are in the hospital, you've been admitted, and you've got blood in your stool. Let's just think of something. You're passing blood. Well, Miss Smith, when is the last time you had your colonoscopy? What? I don't think I've ever had one of those. My doctor never said anything about it. Well, have they checked your stool? Could you do what we call a Cologuard? How many of y'all have heard of Cologuard? Okay, you've seen the commercials. You just give a stool sample, you mail it in through the mail. God bless who works there. I hope they pay them well. I thought about that one day. I was like, gosh, I hope they pay them well. But that's what we're going to talk about, the things that you should have had done as a routine screening. As you all know, with insurance and with Medicare nowadays, they pretty much tell you what you can be screened for that's going to be covered, okay? We're not back in the day where, oh my gosh, I think I may have some lung problems. I need to get a CAT scan of my chest. Nope, it's not going to be approved. It's not going to, there's always some red tape behind the scenes that we have to work with. So we're going to start, and I'm going to have to go between glasses and paper because Tammy can't read that up there. We're going to talk about abdominal aortic aneurysms. This is the large vessel that goes through our abdomen, up through our chest, over to the side of our heart, and it's like a garden hose, basically. It's really tough, but that's your major blood vessel of your body. You should, if you are a male, have been screened for an abdominal aortic aneurysm between the ages of 65 and 75. Who has had that ultrasound done, men? One taker. Two takers. It's because you don't hear a lot about it. Your cardiologist, if you have one, your cardiologist might go over that with you, but they very well may not. So this is going to give y'all some information for that testing that you should have had done. You got to be your own advocate, okay? In the healthcare world, the more knowledge you have, the more power you have to be an advocate for your own body, to know what you should be checking for and what you should be looking for. The next thing we're going to talk about is breast exams. Women, I know y'all just look forward to that annual mammogram, don't you? Just shake your heads. Most pleasant experience we've ever had. It's not. But new testing and new machines that can take better pictures, but they also take better pictures without as much discomfort is what we used to have. They have 3D, 4D, new machines, and it's made a world of difference from where we came from in the old days with mammograms. All women over age 40 should have had a mammogram. How many women have had your mammograms? Self-included. Do this every year. This is Breast Cancer Awareness Month. Grab your pink bow before you leave. But breast cancer is so prevalent with women, and detecting it in the early stages is one of the biggest things that we can do to be successful in treating it. Another thing you can do is not just the mammogram itself, but doing breast exams. Mothers, teach your daughters. Insurance may not let them have a mammogram early. There may not be a reason for it. So teach them to do breast exams, to check for nodules, for lumps, for anything that feels uncomfortable. Women in their 30s, they get breast cancer. Women in their 20s get breast cancer. But unfortunately, we're not at the age yet to where they see the numbers being so high that they cover it for them. So teach your daughters, no matter how young they are, they're in college, they're newly married, teach them to do breast self-exams. And if they feel something, they can follow up with a provider who might order additional imaging of their breast. It could save their life. Next, we will talk about, and this keeps flipping. I did not flip that back in. I was going to do that later down. Next, we're going to talk about cervical cancer screening. Oh my goodness. Women, y'all are getting beat up 2 in a row. This is pap smears. So women, we should have our pap smears done. We should do that at the age of 21. Should be the first pap smear that we have done. We want to do those routinely until the age of 65. During that time, they will test women for a virus that we can get. They'll test you for that one time. It's called HPV. If you've been clear with that and you're over the age of 30, they may change your testing to every 3 years. Women who have had hysterectomies, that changes it up as well. You will talk to your OBGYN and they may lengthen it out, and after 5 years of negative pap smears, they may not even do cervical testing with a pap smear anymore. You can get off the hook because women hate pap smears in general. Anybody loves to go get their pap smear done? No. But just be your own advocate. Make sure you're staying on top of that. And again, women, teach your daughters that. They're busy. They have young children. They're involved in school. They're involved in activities. Grandchildren are having children. That's one of the things they push to the side and don't do. They 2, 3, 4 years start having a problem and they go back in and have their pap smear. So mothers, teach our girls, teach our daughters, teach your daughter-in-laws. Remind them to go get it done and how important it is. Next thing is easy. This is just a blood test that's your cholesterol screening. More and more now, I think we're seeing that your employers, they're having wellness fairs. Insurance are requiring you to do a wellness blood work to keep your insurance the next year. So we're actually seeing this really getting implemented early. We are Southerners. We do not have the best diets. We do have a lot of hyperlipidemia, high cholesterol levels in Alabama, in our entire southern region. We can understand that. I mean, we don't eat everything grilled and baked, and we love fast food. Oh, there's nothing like pulling up during COVID and you just get your food to go in the drive-thru. We like fast food. That's just part of how we were raised and what we eat. But cholesterol screening, all men, all women, starting at the age of 20, and even earlier if you have cardiac risk factors or if you're diabetic, they may start checking those earlier as well. Everyone in here has had their cholesterol checked? Yes, good. All right. Colorectal cancer. How do we screen for colorectal cancer? It's like we were talking about at the first. A colonoscopy versus a Cologuard. A lot of people we see in the office setting says, oh, I'm just doing the test. I'm going to do the Cologuard and mail it in and send on my stool specimen. Cologuard is great, but it only predicts about 42% of polyps that could be cancerous. Whereas you have a direct visual colonoscopy where the camera is actually going in and we can see. It's not just looking at the DNA of your stool sample. The colonoscopy is actually letting them visualize the wall of the colon. You may have just a dark lesion. You may have a polyp that looks suspicious. Well, they can take them out right at that time and do what we call a polypectomy. So 95% are found with a colonoscopy compared to 42% found with the Cologuard. Okay, colorectal cancer is very aggressive. I want to go with the colonoscopy. Cologuard is great for the population that are at high risk for anesthesia or for sedation or have some other irritable bowel where they can't have a colonoscopy. But the colonoscopy is first line. That's your choice if you can tolerate it and you've discussed it with your provider. Another thing, the recommendations for colonoscopy are not as frequent. This is going to be once every 5 to 10 years. If you do the Cologuard and you choose it, they want you to repeat that every 3 years. And remember, you're still at that lower percentage of it picking up the DNA that could be precancerous. Mostly everyone here, you've got 2 GI groups, Dr. Hakeem, Dr. Argawal, Dr. Steele, those are all gastroenterologists here. But our surgeons, we have Dr. Campos, Dr. Diamond, and Dr. Overcash. They do screening colonoscopies as well. We have Tinsley, who is actually one of their nurse practitioners in the office, so they can easily get you set up for a screening colonoscopy if you want to see one of them. You may have had a prior surgery done with one of those surgeons, so you feel comfortable with them. So that's just 5 different providers who could do it. Actually 6 different providers at Coosa Valley who could do a screening colonoscopy for you. All right, let's move along. I am going to move this one. Let's see if it moves. But I know I can tell her next slide. There we go. All right. How many well, if you don't mind, if you're diabetic, we should be checking what's called a hemoglobin A1C. Hemoglobin A1C is the 90-day average of your glucose. People who are diabetic should have this checked routinely, but for men and women over the age of 45, you should know what your hemoglobin A1C was. What's your diabetes marker? What is my number? How many have had their A1C checked? Okay, that's good. That's way more than I thought. At the end of the program, Dr. Wheeler is going to talk to you a little about diabetes and just some of the complications and things you watch for with it. But remember, that also comes in a lot of your employer or your wellness exams or in health fairs and screenings. You can get an A1C checked. And it's just a finger prick. You can do it in the office, it's a finger prick, or blood work where they draw it into a tube. HIV screening. How many in here have ever donated blood? I have. Lifestyle. They screen you for HIV when you donate blood. That's an easy screening if you donate blood. But at one time in your life, you should have a screening. You can always discuss that with your primary care physician. Blood pressure measurements. If you go to the doctor for a cut on your toe, they are going to check your blood pressure, okay? I mean, stuffy nose, anything. Be aware of what your blood pressure runs. Some people have normal low blood pressure. They walk around with a blood pressure of like 90/50, whereas others walk around with a blood pressure of 170/90. Be aware of what your normal, he raised his hand. Be aware of what your normal blood pressure runs before you're ever started on medications or you have just one high blood pressure reading. Lots of times people have what you call a white coat syndrome. They'll come in the clinic and they say, listen, every time I'm at the church and my friend's daughter checks it, it's normal. But when I go in the doctor's office, my blood pressure's just out the roof. And we understand that. That is very common for people to have that little just peak in their blood pressure when they're in a provider office. So know your normal blood pressure. Be aware of what it is. Let's move. We are still on this slide. We're going to go to low-dose CT screens of the lungs. And this is a CAT scan. So it's just the big fancy machine is taking multiple pictures of your chest, okay, from your neck down to your abdomen. It's going to take multiple views and multiple images of your chest. This was started it was probably many years ago they actually implemented, but people were not testing it. Have y'all had a screening CT of your chest, CAT scan of your chest? A lot of people have not. There are a few, which is good, but a lot of people have missed that. It's a one-time screening, basically for men and women between the ages of 55 and 74. Have you smoked at least 1 pack a day for 30 years, or you smoked 2 packs a day for 15 years? That's not the only part. There are some risk factors that go along with that. We're going to kind of review that on another slide. But always know, if you were a smoker in the past, you smoked and you quit, you may be eligible to have this CAT scan done. Next is for women, which is osteoporosis screening. So the thinning of our bones. They become frail as we get older. Not everyone, but the majority of women do. So the age of 65 and up, you should have what's called a DEXA scan, okay? And it's gonna look at the thickness of your bone and how healthy it is. Have any of y'all just ever broke a bone and you weren't really doing any kind of impact? It's what we call a low impact fracture. It's probably because your bones are thin and weak. There's medications that we take now that causes it. There's medications that we treat our thyroid with that can cause it. There's lots of different factors with our hormones. Husbands, don't reply on that. Our hormone levels can adjust, and as they alter, it can cause our bones to thin as well. It's a painless test. Basically, you're just laying on a table while the scan is done of your body. So women, if you're 65 and older, or you were under 65 and started menopause early, then you need to discuss having this done with your primary care as well. Next is our men, which is time. We pick on them a little bit because we have not had too much for the men here. PSA, have y'all heard that? Prostate antigen. Have y'all heard them talk about your PSA, getting it checked? It's become a really controversial topic and how often you get it checked and how regular. It's something you'll want to discuss with your primary care and your urologist. If you're having some obstructive symptoms, meaning you don't notice that your urine outputs is powerful, you're having pain more so in your lower abdomen and near your rectum, or you're noticing some blood in your urine, then you probably need to have it checked. But the thing is, a lot of men over the age of 70 will have a false positive high level of PSA just from the thickness of their prostate overall. So that's something you'll want to discuss with your doctor in general. Before that age, they will test it routinely. We have a new urologist here at Coosa Valley. His name is Lansing Patterson, and his office is over in the professional building. So he is a full-time urologist. He's here Monday through Friday. You can also schedule and see him if you need to as a patient. All right, let's go see if we can make it to the next slide. Oh no, I don't want to forget this one. Sexually transmitted infections. Why would we be checking for chlamydia? Mothers, dads, either. This goes for the age population of 25 and for women who are an elder age who are sexually active and could actually acquire an STI. Chlamydia is asymptomatic. You do not know you have it usually. Until you are checked for it, you have no idea. Younger girls may not know they have picked this up. They get to the age where they're getting married. Now we're going to go start having our family. It can cause infertility. So being checked for chlamydia with your regular OBGYN, even your primary care, is a good thing. Not something that's often talked about, but mother, be an advocate for your daughters. All right, let's see. Breast Cancer Awareness Month, as we talked about having our mammograms and doing our self-breast exams, we want to do that. One thing for women, you want to do it the same time each month and do a circular motion when you're checking your breasts. Raise your arm up, check up under your armpits where it can go into these lymph nodes that go under our arm. Self-exams are the easiest thing you can do. Know your breasts, like I said. Not only does breast cancer affect women, it does affect men. Men, you start noticing any kind of drainage at your breast, what you think may be like a cyst or a hair follicle, have it checked because men do get breast cancer. 1 in 8 women in the United States will be diagnosed sometime in their life. So 1 in 8 down that road, one of you will have breast cancer sometime during your lifespan. 13% of the United States population will have breast cancer as well. It's estimated this year in 2024, over 310,000 women will be diagnosed with breast cancer. Over 2,800 men will be diagnosed with breast cancer. With new detection modalities, increased 3D and 4D mammograms, we're catching it earlier, which is the good thing. So the rates and the 5-year survival rate is now 99%. We have lots of new medications. They have targeted therapy. There's so many different options than what we used to have in the old days. Still remembering, 1 in 5 women develop what we call metastatic breast cancer that spreads to other parts of the body, okay? So when you are a breast cancer survivor and you're past that 5-year mark and you're at 99%, you still continue to follow. You still get your mammograms. You still do your self-breast exams because you are a survivor and we want to keep you that way. You may have to help me play this. We've got a little video about the abdominal aortic aneurysm. This is the one we were talking about. This is a physician, which I got randomly off of YouTube. So we have no affiliation with this doctor whatsoever, but he did a really good presentation to kind of educate you about an aortic aneurysm.
And this is a very common condition. This is something that I see lots and lots of patients for. They get discovered through a variety of mechanisms, and then once they reach a certain size, they may need to be treated surgically, and hence come see a surgeon. So the heart ejects blood through the aortic valve, and then the large artery is called the aorta, which delivers blood to the entire body, save for the lungs, which are on a separate circulation. And an aneurysm is simply a fancy word for a dilation of a blood vessel. But unfortunately, for a lot of patients, these aneurysms don't cause symptoms until they cause a catastrophic problem.
Why is family history an important factor in determining a person's risk for ascending aortic aneurysm?
For certain individuals, they have risk factors for aortic aneurysm. So maybe a strong family history, for example, that tips something off, or even a family or personal history of a genetic condition that leads to these types of aneurysms, such as Marfan syndrome. That would be the most common. We really know of about 30 genes or so that we can actually test for. So when this runs in families, you can actually take genetic screening tests and identify the particular mutation in one of those genes. I think the important piece, if there's kind of an unexplained or unexpected death that occurs in someone's family, is that might actually be an aortic complication, right? And unless one does an autopsy, it may get labeled as something potentially erroneously.
Okay, pretty quick, pretty easy. Remember, this is for males 65 to 75 years old. It's a one-time screening. If you have a cardiologist that's already established, see have they screened you for that in their office. This is 10% of sudden deaths. If you've ever had somebody who just died in your family, they couldn't tell you the exact cause, but they thought it was probably an aortic aneurysm. 10% of deaths that we have no idea is caused by this. There's not always symptoms, that's one thing. It can be very silent. People think the symptoms are more GI related. You have abdominal pain, high blood pressure, pain after eating your meals in your abdomen, and then weight loss. That's just some of the documented signs that people pick up on. By the time you come to the ER, because you're having excruciating chest pain and back pain, we're usually at the point of rupture or dissection. It's starting to rupture. No known cause, genetics is often looked at, but 20% of people with an aortic aneurysm have had another family member that had an aortic aneurysm. So it's something you always watch and annually you keep a check on. Risk factors for it are cigarette smoking, hypertension, COPD, your age being 65 to 75, being a male over a female, and again, the family history. Okay, this was something I thought was kind of significant to talk about. If you look at, everybody talks about what generation we are now. Not what age we are, but what generation we are. So you've got your Gen Z, your 18 to 25. What do they look at? Cervical cancer, of course. They're young, they're just starting their pap smears. Cholesterol, skin cancer. Melanoma is our invasive and there's no cure for it. Melanoma is a skin cancer. Do an annual skin check. Look at your moles, look at your freckles, look at any skin lesion that is changing and looks different. Mental health in 18 to 25. We are getting out of being under our parents. We are in the age of finding ourselves, finding autonomy. We're starting jobs. We're struggling with finances, marriage, relationships. Mental health, huge in 18 to 25. Testicular cancer in men, most commonly diagnosed between the age of 18 to 25. And obesity. Obesity, as everybody knows, that's nationwide that we're trying to stop obesity in children. Everything we can do to make children be more active and cut back on our fast food. Millennials, that's our 26 to 40-year-old, right there in the middle. What's different with them? They're having reproductive issues, a lot of infertility issues. That causes problems with stress, causes problems with relationships. Keep a check on those. It may be your children, maybe your grandchildren. Once again, obesity at the bottom. Our Gen X, so our adults, we're starting to see more breast cancer, more colon cancer, heart disease. This is about the time that we're having blockages being picked up, outpatient caths, heart attacks, high blood pressure, cholesterol screening, and once again, obesity is just sitting there at the bottom. Baby boomers, our 57 to 75-year-olds, the biggest population in the United States right now, baby boomers. Breast cancer, colon cancer, heart disease, high blood pressure, cholesterol. There we see our osteoporosis sitting in where we should have had the DEXA scan, prostate cancer in our men, stroke. So we're adding on stroke. That's because we want to control our blood pressure. We want to live healthy lifestyles. And then depression. Why would we be screening for depression in our 57 to 75-year-olds? Your life's changed. You've got out of it, you've gone into empty nest, you've gone into retirement, we're living on fixed incomes. Some of us have lost our spouses and we're just into living by ourselves. Depression in our elderly is huge. No one wants to ask for it. Nobody wants to talk about it. So that is a new screening tool that Medicare actually has. When you do your annual wellness exam with your primary care physician, they'll screen you for depression right there in the office and ask you questions. So if you wonder why they're asking you about 14 questions that's on this page, that's what it's for. Medicare wants us to start screening for depression in this age group. Silent generation. I don't know if they're silent because my grandmother was not silent and she is in that generation. So I don't even know why we call it the silent generation, but 76 to 93. Arthritis, of course. But one thing I always tell patients when I worked in the clinic setting is don't think you feel bad because you're getting old, okay? Getting old doesn't necessarily make you feel bad, okay? You know your body and you know what your body normally feels like. It doesn't go from A to Z in one day, okay? When it does that, something's going on. Your body's talking to you. Be your own advocate and don't ever get it just peeled off that it's just old age setting in or arthritis or your joints. It very well could be something else. Always be your advocate. Diabetes, yes, diabetes is prevalent and you will see it more then. And diabetes, if you are doing lifestyle modification and all the medications. Y'all have to see a diabetes commercial at least 5 times a day for a medicine that they have now. It is always on. There's an injection, there's a long-acting, there's a pill form. There are so many diabetes meds out there. Congestive heart failure, high blood pressure, osteoporosis, prostate cancer, stroke, and depression. The same thing in these age groups. Stay healthy, stay active. If you're widowed, find a friend group, find a church group. Be active, because if you don't use it, what do? Lose it. Yes, that's right. Let's see what else we got. And the one that gets in there, we get sedentary. Sedentary leads to obesity. We're just going to sit there instead of walk. I'll call my grandson. He'll come over and bring me some supper tonight. May have a little dog. I'm just going to put it out in the backyard instead of walking it. Let's move. You got to move. Obesity can lead to diabetes, cardiovascular disease, high blood pressure, joint problems, sleep apnea and obesity. If your spouse has to have a CPAP machine, you know what I'm talking about, because it's bothersome. Even some cancers are linked to obesity. How do we judge that in the clinical setting? It's by your BMI, your body mass index, which takes your height and your weight in consideration and calculates a percentage that puts you into either a healthy weight, overweight, or an obese weight. Y'all all have a copy of that sitting in front of you, and it's really just preventive health information. We did not go over vaccines because that's so controversial, and it's just been yelled at us for the past 4 years with COVID, but your physician will screen you for all vaccines that you're eligible for. Now, Dr. Wheeler is going to talk to us just about what she calls her 1 minute. I can tell you what you need to watch for with diabetes. Jennie Wheeler is internal medicine, so she's not family. So diabetes is one thing she saw a lot of in her practice. But remember, she and I do not have an office practice. We only see you in the hospital setting. Diabetes is just one of the biggest conditions that we see all across the United States and all ethnic backgrounds, and so much of it can be controlled with just exercise and lifestyle modification, and you can adjust to maybe one medicine. Some people aren't that lucky. Their bodies just quit producing insulin, and it can't be controlled that easily. But I will have Dr. Wheeler come up here with me, and she is going to use this microphone.
I really don't think I need that. I bet everybody can hear me. She's loud. Is it on? So I will use this anyway. Yeah. So Tammy put this very nicely. I put it a little more bluntly. She talked earlier about the A1C. The A1C is an indication of what your blood sugars are. So if your blood sugars are really high and you have a high A1C, then that extra blood sugar that's flowing through your blood vessels acts as a poison, and it destroys those blood vessels. So when you destroy those blood vessels, that's where you get blindness, because it affects the blood vessels in your eyes. It affects the blood vessels in your kidneys, and you go on dialysis. And it affects the blood vessels in your feet because they're furthest from your heart, and you end up with vascular disease and amputations. So our screening tests for each of these, you need to go to the eye doctor and have them look at the back of your eye and check the blood vessels. So you need an eye exam as part of your diabetes screening. You need your primary provider to check for protein in your urine, and that assesses how well your kidneys are doing from your diabetes. And then there is a specific test, I like saying this word, monofilament. They test how well the feeling is in your feet, and that tells us if you're having the beginnings of neuropathy or not. So those are the 3 tests that we need to screen for the complications of diabetes: eye exam, kidney protein, and feeling in your feet.
Yep, do we have any questions for Dr. Wheeler and Tammy? Any questions?
Surely.
Yes, Mr. Ross.
On the aortic examination you were talking about, with that procedure, and I don't think it's ever been mentioned to me, is that procedure something that would normally be covered under Medicare or one of your insurance arrangements?
It is covered by Medicare. This is one of CMS guidelines, and it is a one-time screening test, and it is an ultrasound. I'm not sure that I actually said that, but it's an abdominal ultrasound. So they just put the gel on your abdomen, and they'll look from the top at your heart down to, because there are different types of aortic aneurysms. It can be on the arch of the blood vessel that goes to the heart. It can be in the middle of your abdomen, just bulging right here. And then it can involve the kidney arteries right here in your abdomen. So there's 3 different places it can be. But yes, Medicare, it's 100%.
And that, it has to be ordered by your physician, and our radiology area does perform that
Yes,
service.
they do. Yes, sir.
Any more questions? You've got a wealth of knowledge up here. All right. Well, let's give a big round of applause for Dr. Great kick-off to our series. And right before we close and drop our door prizes, we have a few auxiliary members here. Mr. Ron, Miss Judy, and did you?
Now I know why y'all stayed, there's door prizes.
Yes.
Okay. And Mr. Ron is going to give a little pitch to you all, if you don't mind.
Judy? I want to thank everybody for being here today. I'm Ron Sims, and I am a fairly short-term resident of Sylacauga. Been living here full-time for about 8 years. I am a member of the board of directors for the foundation for the hospital, and I also am a proud member of the Coosa Valley Auxiliary. And I'm sure anybody who's been to the hospital has seen Judy, me, Linda's here, and several other people who are a part of the volunteer staff. I want to thank Jayla for allowing us to speak to you for just a couple of minutes regarding the services we are providing, and more importantly, to offer you an invitation to join our group. And obviously, you don't know how much you will benefit from being a part of this organization, both physically, emotionally, and spiritually on many occasions. So just a few things. What we do, there are basically 3 specific services we provide. Number 1, you see us when you walk into the lobby. There is a member there at the information desk who can give directions, tell you where to go, etc. We also, so that's one person who would be involved with that duty. The second duty, of course, is for the patient transport services. And that would be if we are bringing in by wheelchair someone who comes to the main entrance that may not be able to walk easily. So we can transport that person by wheelchair to their destination. We also, obviously, when your procedure is finished in the day surgery unit, GI lab, or you're being discharged from the floor, we would be there to wheel you out to your vehicle. I always tell Judy, we are the first person that you generally see when you come in, and if we can do anything to ease your concern or make you feel comfortable, that's one of our main missions. The third part, we've got the front desk, we've got the patient transporter, is the person that works at the day surgery unit desk, and that person will help procedurally once you are going up for your surgery, GI procedure, or whatever. She gets your folder, she tells you exactly what you need to do, and provides information while you're in your procedure to family members who may be there. So we've got those 3 specific areas that we work in. Now, as you can see, some of these jobs just involve sitting at a desk or just being there to give information and direct people. And we have that other job, which I thoroughly enjoy, is the patient transport. I want to be physically active. I want to be directly dealing with the patient, and I thoroughly enjoy the physical activity that provides. So anybody that's comfortable sitting at a desk, being willing to talk to people, being hospitable, there's certainly an area for you. If you want to get active and move, we can be a patient transporter. But in any event, we are looking for men and women. And I'm sad to say that I'm the only doggone man that works in the auxiliary right now. But we do have two others that are in the loop that will soon be joining us. And so I'm looking for a few good men. And I'm also looking for a few good women as well to help do that. So right now, we are in a shortage of volunteers. We do not have sufficient numbers to staff either the front desk or the day surgery unit on Fridays. So we certainly need people who could fill that role. And we certainly there are a couple of openings right now for the day surgery desk that we would heartily recommend anyone who'd be interested in doing that. All right, a couple of the housekeeping details. We only ask, we're not asking for much, okay? We only ask that you could commit to 1 4-hour shift per week, either from 8 to 12 or from 12 to 4. Just one shift, if you can do that, that is all we're asking for. I work 2 shifts. I like the idea of movement, so I transport on Wednesdays and Thursdays. So that is a very, inconsequential, if you will, time. You're not devoting your whole life to doing this, but you can't believe just how comforting it can be knowing that you're providing a service. So the benefits, your pay doubles every 6 months you're there. It goes from 0 to 00. But I am happy to say that for any shift that you work, you are given a free meal at the cafeteria. So you work your shift, go get you a meal. You work 2 days, you get 2 meals, when your shift is completed. So the application process, Jayla has brought some applications. There is a procedure you go through. You fill out your application. It is reviewed, and as you can imagine, since this is providing services for a hospital, there is a background check. For like normal jobs, there is a drug screening that would go through, and Judy normally makes go through the savage initiation process. I'm just teasing. No initiation, but you will be connected with a member who you will shadow for a session or so that you will know exactly what you need to do. And Judy, do we have fun?
We have fun every time we work. It's all of us fun. And it's really rewarding. I recommend it to anybody.
And it's amazing. I've only been doing this for a few years, but we have some people who have been doing this for 25 years or more that have devoted that time over that period. And I cannot think of a better organization to be providing services to this hospital. And it is an absolute jewel that we have in this community. So Judy and I will be at the back. We would love to talk to you and give you an application and answer any questions you have. If you want to go home and think about it, the next time you're in the hospital, stop by the front desk. We'll give you an application and we'll welcome you with open arms. Thank you.